Hi students, this is me Dr. Aditya once again, and today we are back with very important topic in psychiatry. This is delirium and psychosis. I hope after studying this slide and presentation you will be able to solve most of your uh, entrance examinations from USMLE Plaver and Clicks questions. Okay, and yes, the most of the contents here are from first aid, and I have also added some questions for your practice at the end. Okay, so please go through this, and I hope you will be quite able to solve all those problems and get very good marks in examinations. Now let's proceed. So here in this presentation we'll be talking about delirium psychosis and hallucinations. So delirium is like waxing and waning of the mental status with acute onset and impaired attention. So all three phrases are important here: waxing and waning, acute onset, and impaired attention. Okay, delirium is a sudden change in consciousness that often fluctuates over hours. So that's, we said, waxing and waning. It fluctuates over hours to days, so patient may seem better at one moment and worse at the next. Key features include disorganized thinking, visual hallucinations, misperceptions such as illusion, agitation, and a disturbance in the sleep-wake cycle. There will be a disturbance in sleep-wake cycle. The most important exam clue is inattention, which is the hallmark finding. So whenever you see here delirium, you have to understand this is acute onset. This is it has waxing and waning, that means fluctuating course, and there is always impaired attention. There is a disturbance in sleep-wake cycle, and the person may experience disorganized thinking, visual hallucinations, and misperceptions, agitations. Okay, and delirium, one good thing about delirium, it is a reversible condition when the underlying cause is treated, and then it gets healed. High causes to remember include infection, medication, intoxication, or withdrawal, metabolic abnormalities, and hospitalizations in older adult. So USMLE high yield, its delirium is caused acute onset, fluctuating course, waxing and waning course is reversible, attention deficit is the hallmark. Now we will try to understand what is the etiology and presentation of delirium. Usually secondary to an identifiable illness. Example, delirium can occur with CNS disease, infection, trauma, substance use, withdrawal, metabolic or electrolyte disturbances, hemorrhage, urinary or fecal retention, or sometimes with the medications like anticholinergic, especially in older adults. Delirium is often multifactorial in hospitalized patients. So in the examinations, the questions will be framed like a 50-70 years old man who had pneumonia or some infection, and then was brought to the hospital, and he has now fluctuating mental status, and he has changes in his sensorium. Okay, and then you have to identify it as delirium. Okay, so most common presentation of altered mental status in the inpatient setting. So the patient, in most of the cases in examinations, and the beginner will explain that the patient was hospitalized, especially in the ICU or during prolonged hospital stays. And then the symptoms of delirium will be given. So delirium is changes in sensorium. Okay, all this etiology that we discussed, that can be summarized as, or easy to remember, in the form of pneumonic as eye was death, in which eye is infection. In UTI or pneumonia causes delirium, especially in elderly population. Similarly, withdrawal, alcohol or benzodiazepines withdrawal. Acute metabolic conditions like electrolyte abnormalities, renal or hepatic failure causes delirium. Trauma or CNS pathology, hypoxia, deficiencies in vitamin B1 and B12 causes delirium. And endocrine disorders, acute vascular disorders, toxic or medications like anticholinergic, opioid or benzos can make us in this condition, and heavy metals also lead to these conditions. Step 2 and 3 plural is that in elderly patients, UTI and pneumonia are the most common triggers of delirium. So if you are ever seen elderly patients, UTI and pneumonia are the most common triggers of delirium. Always check. So if it is a step 3 examinations, then they'll ask what to do after you'll be able to diagnose delirium. Then you have to check, okay, I'll do urine analysis and chest x-ray. And easy meso diffuse background rhythm slowing. In delirium, there will be diffuse background rhythm slowing, and in psychosis, it will more or less be normal. Now, the treatment of delirium is identifying and manage the underlying condition, is the primary treatment approach. Treat the root cause, for example, give antibiotics for infection and correct electrolyte abnormalities. Orientation protocol is that non-pharmacologic care, that is reorientation with the clock, calendar, and familiar faces, needs to be done to the patient so that their orientation can be brought back. Okay, early mobilization, hearing aids, glasses, normalize the sleep-wake cycle, and reduce the unnecessary lines or catheters to prevent further infection. This needs to be done. And antipsychotics, sometimes antipsychotics like haloperidol can be prescribed if the person is in delirium. Is often the first line for agitation at low doses. Haloperidol at low doses will help it, and quetiapine is preferred if the person has Parkinson's disease or Lewy body dementia. Now, this is important point for examinations. Avoid unnecessary restraints and drugs that may worsen delirium. So if the person is having some anticholinergics, and also in the ICU and all these delirium symptoms are given, what to do first is stop anticholinergics, stop benzodiazepines, stop opioids. Okay, and again, this has to be from beginning to beginning. We have to understand the scenario and then we have to choose these options. And step 2 and 3 pro is that benzodiazepines are contraindicated in most delirium. Don't think that the person is agitating, maybe I give him benzodiazepines and then he will calm down. No, we'll not do that. We go with haloperidol, or if the person has Parkinson's, we go with the quetiapine, not benzodiazepines. They are contraindicated in most delirium except for alcohol or benzodiazepine withdrawal delirium. So when there is a delirium case, if you have to pick a drug, give haloperidol or quetiapine. But if the delirium is because of alcohol withdrawal syndrome or benzodiazepines withdrawal syndrome, then we go with benzodiazepines. Okay, this is very important for examination's point of view. And next is psychosis. Psychosis is a loss of contact with reality. It is characterized by delusions, hallucinations, disorganized thought or speech, and sometimes negative symptoms, especially in schizophrenia. It can occur in primary psychiatric illness, medical disease, or substance medications use. So when you hear someone saying psychosis, you can think about maybe he has delusions, that is psychosis, maybe he has hallucinations, that is psychosis, maybe he has disorganized thoughts or speech, or maybe he has schizophrenia and some negative symptoms. So any of these things is psychosis. Okay, and in psychosis we have to understand that there is a loss of contact with reality. In delirium is something different. Okay, so yes, in psychosis you have to remember that will be the loss of contact with reality. This is important. Okay, and it can occur in other beyond those conditions like delusion, hallucination, disorganized thought and speech, schizophrenia. It can also occur in psychiatric or other psychiatric illness and medical diseases or substance or medication use. So now let's understand what is delusion. Delusion is a false, fixed, idiosyncratic belief that persists despite evidence to the contrary and are not typical of a patient's culture or religion. Example, a patient who believes that others are reading his thoughts. So this is delusion. So in delusion, the person will have false thought, false belief. It's fixed. He cannot change that. It's fixed in his brain. And that perceived despite evidence to the contrary and are not typical of a patient's culture. So if a person has false belief that is fixed, then that cannot be changed even if someone tries to convince him, and that is not somewhat related to his cultures, then that sort of thought is called as delusions. Okay, types include erotomanic, grandiose, jealousy, prosecutory, somatic, mixed, and unspecified. Now, disorganized thought means like in this condition, the person will have disorganized thought. Okay, and because how we know that he has disorganized thought? Because his speech may be incoherent. He may have word salad. Similarly, his speech may be tangential. Tangential speech is a speech in which they communicate, is a type of communication disorder in which a person diverges from the main topic, often giving irrelevant information and never returning to the original point or answering the question. That is tangential speech. So the person with the disorganized thought may show tangential communication or speech. He may exhibit word salad during speaking, and he may have derailed thought. That means losing of associations. So sometimes he talks about east and then suddenly he talks about cows. Okay, so that is disorganized thought. This also is type of psychosis. Delusion is a psychosis. And sometimes negative symptoms, we said a flat affect, showing no emotions, alogia, poverty of speech, abolitions, lack of motivation, anhedonia, could not experience happiness, asociality. All these can be seen in schizophrenia, and this is also can be related to psychosis. And whenever you see any negative symptoms, then you will know that that person is very difficult to be treated now, and we can say that he or she has poor prognosis. So for examination's point of view, quick recap: cause of psychosis can be primary psychiatric, like schizophrenia, bipolar with psychotic disorder, brief psychotic disorder, schizoaffective disorder. Any of this can be a cause of psychosis or psychotic symptoms. And similarly, there can be secondary causes like CNS lesions, autoimmune encephalitis, thyroid storm, SLE. Any of this can cause psychosis too. And similarly, sometimes there will be substance-induced psychosis like stimulants, PCP, cannabis. This can cause psychosis too. In step one, we have to understand this, that positive symptoms like hallucinations and delusions respond to antipsychotics. So if the person has psychosis and he or she has positive symptoms like hallucinations, delusions, or disorganized thoughts, then these can be treated with medicines. Okay, so then they have better prognosis. But if a person has psychosis with negative symptoms, then we have to understand they are very hard to treat and often indicate the worst prognosis. Okay, this is important. Okay, now after psychosis, we will be learning about hallucinations. Okay, this is another important topic, and so yes, after this it's hallucinations. So hallucinations is perceptions in the absence of external stimuli. Example, seeing a light that is not actually present. So if you are perceiving something in the absence of external stimuli, that is hallucinations. But in contrast, if you are but if you feel misperceptions of real external stimuli, then that is called an illusion. So there is some difference between hallucinations and an illusion. Hallucination, there is no external stimuli, but still you perceive the thing, that is hallucination. But if there is some external stimuli, but if you misperceive the thing, then that is illusion. Now let's tell some examples of hallucinations, and this is very important also in examinations. So auditory hallucinations is more common due to psychiatric illness like schizophrenia than in neurological cause. So they may ask you, a person has schizophrenia, what type of hallucinations is most common? And then we have to say auditory hallucinations is most common in a psychiatric illness. Okay, and this can include voices, music, sound, and is most common hallucination type. Sometimes it's given visual hallucinations, but visual hallucinations is more common due to neurological diseases, like example dementia, delirium, drug intoxication, than psychiatric illness. So whenever there is psychiatric illnesses, then most of the time you think about auditory hallucinations. But if there is delirium, neurological cause, intoxication, drug intoxication, then you may think about visual hallucinations. Visual hallucinations can be simple, like seeing of the lights and the colors when there is no light or color in front of you, or sometimes it may be complex, like seeing of actual people or animal. Okay, that is visual hallucinations. And tactile hallucinations is common in alcohol withdrawal and stimulant use. Example, again, we say cocaine crawl is a type of delusional parasitosis, often described as bugs crawling on or under the skin. So this is example of tactile hallucinations, and seen in alcohol withdrawal and sometimes with cocaine use. Olfactory hallucinations often occur as an aura of temporal lobe epilepsy. And this burning rubber is a hint in examinations. If someone says burning rubber, then if you have to find the lobe of the brain where it is affected, then we have to say it is temporal lobe affected. Here, in case of temporal lobe epilepsy or brain tumors, you see olfactory hallucinations. Sometimes with focal seizures also we can involving in the uncus can lead to olfactory hallucinations. Gustatory hallucinations is rare, but also in seen in epilepsy may present as a strange or metallic taste. Hypnagogic is important in examination. Hypnagogic go means going to sleep. So the hallucinations that we perceive just before going to bed is hypnagogic hallucinations, and it is associated with narcolepsy. But again, it can be benign in healthy individuals. And hypnopompic hallucinations is it occurs while waking from the sleep, and sometimes it's seen in narcolepsy, and again can be benign in healthy individuals. So Step 1 in the questions you have to understand is that auditory hallucinations think psychiatric disease, visual hallucinations think about delirium, dementia, and drugs, tactile hallucinations thinking about alcohol withdrawal and stimulant use like cocaine use, hypnagogic and hypnopompic hallucinations is seen in narcolepsy. Now let's differentiate between delirium versus psychosis. So delirium, it is acute onset, hours to days, and psychosis is subacute or chronic. Delirium is fluctuating course, that means waxing and waning type of consciousness will be there. Okay, whereas in psychosis it is relatively stable course. In consciousness is impaired in delirium, that is they have clouded sensorium, whereas in psychosis the consciousness is intact, is usually intact. Delirium has impaired, severely impaired attention, whereas psychosis there is relatively preserved attention. Hallucinations may be predominantly visual, but in psychosis it's predominantly auditory. Orientation is disoriented to timeless and person in delirium, whereas it is usually oriented in psychosis. Sleep cycle is severely disrupted in delirium, but may be disrupted in psychosis. Age is diffuse slowing in delirium, but usually normal in psychosis. Reversibilities, delirium are reversible mostly, whereas in psychosis it's mostly chronic, often chronic and relapsing. Common causes include medical illness, drugs, withdrawal, metabolic. Remember we talked about mnemonic I was death, so you can all of them are causes of delirium. Whereas psychosis is mainly psychiatric, bipolar, or substance abuse. Age group is elderly or ICU patients. This is hint in examinations. Okay, the patient will be elderly, ICU patients, and have waxing and waning type of consciousness, and that is delirium. Whereas in psychosis it's mostly for young adults. In example, in schizophrenia it's between 15 to 35 years. Psychomotor is hyperactive or hypoactive in case of delirium, whereas in psychosis it is also variable. So USMLE key point, the key differentiation is consciousness. Impaired consciousness is impaired in delirium and intact in psychosis. This is important to understand. In psychosis, consciousness is intact. Visual hallucinations is seen in delirium, whereas auditory hallucinations is seen in psychosis. Step 2 and 3 probably is that a patient with non-schizophrenia who suddenly worsens with confusion or visual hallucinations, the delirium superimposed on psychosis. Always rule out organic cause first. Okay, now these are some of USMLE practice questions. You can pause the video here and try to solve this. I hope you'll be able to solve this with the content that I just taught to you. Then yes, there's some questions for USMLE step 1, step 2, and step 3. I want you to go through them, pause the video, solve the questions, understand the concept, and proceed. Okay, and also if you are NCLEX preparing students, there are questions for you too, so go through these questions, and I hope you'll be able to get a holistic approach, holistic knowledge on this topic. And I strongly believe that you can solve any problem questions from delirium, hallucinations, and psychosis in examinations if you go through them. Also for nurses, I have added few slides. This is nursing consideration NCLEX IL. Please go through if you are studying for nurse. And yes, this is somewhat important. With this, I'd like to end my presentation. I hope you will find this very helpful, and you'll thank me in examinations when these questions come in examinations, and you'll be able to solve them. Almost in every examinations in USMLE, you find at least a question from delirium or psychosis or hallucinations. So be prepared with this. With this, I'd like to end my presentation here. See you in next video. Bye bye.